Greetings. Thank you for this opportunity to present this topic, current management of colonic lesions, characterization, and treatment. I bring good wishes from the Texas Medical Center and my institution, and the University of Texas, MD Anderson Cancer Center, Houston. At the outset, I would like to thank Dr. Cortez, Dr. Hernandez Guerrero, Dr. Levy, Dr. Tanimoto for this kind invitation. I'm really grateful to you all for this opportunity. I would like to share with you that I do not have any conflicts of interest, and I would like to thank Dr. John Stoline for the endowment, Mr. Charles Butt, and also Angela Deal, medical illustrator, who has helped me with this presentation. So when we think about colon polyps, I think if you go to the bedside after completing a resection, you would like to share with the patient that you were able to resect the polyp completely and also safely, so that they're happy with the outcome. And if you could tell them that the polyp is most likely to come back as benign, the patient and the family will leave happily. So that is our goal. So how do we go about achieving this goal? It all depends upon your patient selection and understanding about which polyps can be resected by endoscopic mucosal resection. And that will be my focus of this presentation. So let us go back to the basics, and it's important to understand the anatomy of the colon wall. As you can see here, the mucosa has epithelium, lamina propria, and the muscularis mucosa separates the mucosa from the underlying submucosa. And let me take you through the stages of colorectal neoplasia. If it is limited to the epithelium, or whether it goes into the lamina propria, and sometimes with advances in the stage, it can penetrate the muscularis mucosa, enter the submucosa, when we call that as adenocarcinoma. And if you understand this process, you will be able to manage your patients with colon polyps better. So as you can see here, let me summarize. When the lesion penetrates the muscularis mucosa, it becomes invasive adenocarcinoma. And when it goes into the submucosa, but is limited to the superficial submucosa, we as endoscopists still have a chance for curative resection. When the lesion is limited to epithelium, either in the form of a low-grade or high-grade dysplasia, or it goes into the lamina propria and even to the muscularis mucosa, it is called intramucosal cancer. And lesions up to intramucosal cancers, and maybe some of those that go into the superficial 1/3 of the submucosa, are amenable for endoscopic resection, either with endoscopic mucosal resection or with endoscopic submucosal resection. The reason why the colon allows us to resect when the lesion goes into the superficial 1/3 of the submucosa is because of the sparsity of the lymphatics. Less than 1% of the lesions that go into the submucosa will end up in the lymph nodes. But that percentage increases when it goes into the middle third and into the lower 1/3 of the submucosa. So this figure is really critical to figure out how do you manage a patient with a colorectal neoplasia. So for lesions that are small and limited to the epithelium, adenomas, for example, that are less than 3 millimeters, you could get it out completely with cold biopsy polypectomy. When it goes beyond 4 millimeters to 9 millimeters, they're best taken out by cold snare resection. You should not be using a cold biopsy polypectomy for lesions larger than 3 millimeters because of the risk of incomplete resection. When it goes to 10 millimeters or more, then as long as you're able to resect it completely, you could get away with endoscopic mucosal resection. When the lesion goes into the superficial one-third, that is early superficial adenocarcinoma, if the lesion is small and can be removed and blocked, you could consider endoscopic mucosal resection. If the lesion is large and you cannot resect it and block, you may want to consider endoscopic submucosal resection. Sometimes you may have a lesion that is large, but you are not able to offer endoscopic submucosal dissection. But if you have a dominant nodule and you're able to submit that nodule in a separate bottle and resect that as an en bloc, you could still get away with endoscopic mucosal resection of those cases. However, when you have lesions that go into the deeper portion of the submucosa, they will require surgery in otherwise healthy people. In some cases who are at a high risk for surgery, one option that is coming out is endoscopic full thickness resection. Although the data on this for this problem is rather limited, and one needs to wait for a little more to have a better understanding. So with that understanding, now let us look at a polyp and characterize it. So when you have a polyp in view, it's important to take a wide shot and freeze the frame. Take a little bit of time to examine that lesion. And the first thing you should ask yourself is, are there any features of cancer? Features of cancer that could be identified easily and maybe with a little bit of dye spray include the following. If there is an expansion of the fold, as you can see here, you should consider that there is cancer with submucosal invasion and expansion of the fold. Something to keep in mind. When there is submucosal involvement by cancer with a desmoplastic reaction, it could actually draw the folds together and leads to fold convergence. Expansile appearance, fold convergence should be looked at whenever you're evaluating a lesion to say whether it is cancer or not. Another feature is if there is fullness. As you can see, there is fullness in the fold here, and that is another feature of cancer. So when you see a lesion from a distance, you should ask yourself whether there is cancer or not. And if you think there is cancer, you're leaning more towards surgery. On the other hand, if you do not have any of these features of cancer, then you're spending your time to go a little bit closer and take a close-up shot. Look at the edge and define the edge. Recently, there are some reports to indicate that unless you take a closer look at the edge, you may be missing what we call subtle skirt lesion around that edge. And that subtle skirt lesion, if it is not included in the resection, it is likely to come back. So something to keep in mind. So once you say that it is not cancer and you define the edge, and if there is a skirt lesion, you define that as well, Then you focus on the surface of the polyp. And if you, depending upon the endoscope you use electronic chroma-endoscopy, or if in case you are more comfortable, you could spray some indigo carmine to evaluate that further. When you do dye spray, when you do electronic chroma-endoscopy, you're looking at few things. You're looking at the pit, and you're looking at the vessels surrounding the pit. And this is important to keep in mind. When you have an adenoma, there is going to be much more prominence of these vessels that show up as much more browner, and that indicates that you're dealing with not a hyperplastic polyp, but an adenoma. So something to keep in mind. So now, with this understanding, let us look at what a hyperplastic polyp looks like under NBI. It looks the same color as the background, and you have uniform dots, white dots, as you can see here, and you don't see, you see a homogeneous appearance. And this is a classic appearance of a hyperplastic polyp. Hyperplastic polyps in the rectum and sigmoid, when they're small, don't need to be removed. Anything above the descending colon, we always remove them routinely. Here is a classic appearance of an adenoma. The lesion looks on NBI darker than the background, and you can see darker vessels surrounding tubular pits or branching pits. This is a classic appearance of a tubular adenoma. When you see a lesion, as you can see here, and it is amorphous with a loss of pit pattern, and that is and the vascular pattern that you see here as you go to the center is disrupted, that is suggestive of cancer. So we talked about how to identify a hyperplastic polyp, pale looking, similar to the background. If you have a darker brown appearance with a branching pattern or a tubular pattern, you think about tubular adenoma. And if you see disruption of the vascular pattern and the pit pattern and has an amorphous pattern, you think about cancer. So once you decide that you're dealing with a benign lesion and you want to cut it, how do you go about cutting it? So we talked about this briefly. Again, for smaller lesions, core biopsy polypectomy. For medium-sized lesions less than 10 millimeters, cold snare. Although there is some literature out there where some of the endoscopists are using cold snare resection with submucosal saline injection for larger lesions as well. For larger lesions, routinely, I think the best way to resect is endoscopic mucosal resection because you have less complications because the submucosal saline prevents deeper thermal injury. If in case you suspect cancer, then it's better to go with ESD. And if it is obvious cancer, you should send the patient for surgery. You should also keep in mind the role of full thickness resection in some of the high-risk patients who cannot go for surgery. So this is what I do. I would like to now focus on endoscopic mucosal resection because majority of the patients that we see in our practice can be managed with just two things, saline injection and a simple snare. It will be very cost effective, and that's what I do in my practice. And as part of the practice, it's always a good idea to share with your team what type of polyp are you going to cut if that polyp has been referred to you. And also have a game plan of sharing with your team what type of equipment do you need so that you have everything ready in your room. The most important thing for therapy is your ability to reach the cecum with a relatively short scope without loops. You could easily reach the cecum between 60 to 70 centimeters, even in somebody who is about 5'10" height, or even 6 feet, about 70 to 80 centimeters for a little bit taller people. And if you're able to reach the cecum in 60 to 70 centimeters, and by gently turning your thumb and rolling the insertion tube, you should be able to move an area. Say, for example, you think about ileocecal valve is your target area. You should be able to rotate your scope and bring the ileocecal valve to 6 o'clock, 9 o'clock, 12 o'clock, and back to 3 o'clock without much difficulty. And then you should be able to hold that position in that stable position by pressing on the insertion tube to the side of the bed with your thigh, so that you can free your right hand to do whatever is needed. That is something I would suggest that all trainees should practice to reach the cecum, not necessarily fast, but with a short, straight scope. So that is the key thing. As you can see here, the physician is telling his assistant, hey, we got a short straight scope. And it is easy to bring the lesion to the lower 1/3 of the operating field. And that is where all your instruments come out and you're able to do the resection. So let us go through steps for EMR. First step is injection. And how do you inject? There are a few things that I want to share with you up front that you should avoid. You should avoid this. You should not bring your catheter out and ask your assistant to plunge the needle and inject. In that case, what happens is the needle has gone through and through that thin 3 millimeter cecum that has been distended, has become much thinner, and the needle has gone through and through the wall, and you deposited all the fluid outside. If that happens, you gently pull the needle back and then inject to find the submucosal plane. So something to keep in mind. So don't do this. On the other hand, if you are injecting and instead of getting into the submucosa, you enter into the mucosa and create a mucosal bleb. In that case, do not pull the needle out, because then you will not be able to find the submucosal plane easily, as it tends to leak. So what you do is gently push the needle a little bit and then find that submucosal plane and inject. So a couple of things I wanted to share with you up front. So now let us talk about how do you find the submucosal plane and create a beautiful injection so that you could lift the lesion the way you want using a technique called dynamic submucosal injection. So first step, ask your assistant to pull the needle out. Then make sure that he flushes so that you are not accidentally injecting air that has not, because the needle has not been primed. So by asking the needle to be flushed, there are two advantages. One advantage is you know that your needle is primed, so no question of injecting air. The next thing is, by injecting, you would know where the fluid moves. And if the fluid moves away, you know that your lesion is not dependent, and that's where your lesion should be. If the lesion is non-dependent and you cut, and if there's bleeding, you can find that bleeding spot very easily. If the lesion is dependent, that means the fluid is sitting there and you cut the lesion and it bleeds, you can't find that bleeding spot because the blood pools there and you will have a hard time finding the bleeding spot. So when you're doing a resection, try to keep your lesion in a non-dependent position so that if in case there's bleeding, you can control the bleeding easily. So how do we do the plane? What I do is I hold my uh, catheter just one finger to two fingers above my injection, my biopsy port, and I make a gentle move. And as I move in, it gets into the submucosa. I don't know whether I got into the submucosa. So the best way to avoid injecting a lot is I ask my assistant to tap, 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 tap on the plunger. That allows a small amount of fluid come out. And then once you know that there is a small amount of fluid getting into the submucosa, you will see a bleb. And then you can ask your assistant to inject a little bit faster, and you can direct your needle the way you want so that you get a nice, good submucosal lift. So let us go through the steps. So step number one, you make a gentle push about 1 to 2 fingers that's there above the biopsy port. You just push, and once you're in the wall of the colon, then ask your assistant to tap, tap. And as you find yourself that the needle is in the submucosa, then you look up with your knob, up down knob, looking up, and then pulling your needle back so that the submucosa fills up. Typically, I inject in one spot for a 10-20 millimeter lesion and direct my needle in whatever direction I want so that I get a good lift and make that lift come in such a way that I don't have to struggle with my snare for resection. So you plan that. Then the question is, how do you cut? And what do you use for the cut? I use a stiff snare for my cut. And as you can see here, my electrosurgery unit was just in front of me. That is always important. You want to see your electrosurgery parameters in front of you. I typically use Endocut Q313. And in the last couple of years, yeah, I've changed my right side coagulation settings to from a force to soft coagulation. I will explain to you why I've done that. So I typically put soft coagulation 4 and 80. So let me take you through what is endocut Q means. Effect 3, duration 1, interval 3. What is effect 3? If you set it up as effect 1, there is no coagulation at all. Effect 2, you may have a little bit of soft coagulation in between your cuts. The red marks are the cuts. And in effect 3, you may have a little more, and effect 4, a lot more. So by putting an effect 3 in between your cut, the red bars are the cuts, you have some coagulation happening. Then the question we talked about, this is what happens. Effect 1, you have no coagulation. Effect 4, you have a lot more coagulation. In between, you have a little bit less. Let's talk about the duration. There are 4 settings for duration. Setting 1, 2, 3, 4. As you can see, the bars lengthening. With the pedal on the yellow pedal, foot on the yellow pedal, with the effect 1, you have a short duration cut. With effect 4, you have a longer duration cut. For a much better control of your cut, it's better to keep the duration at 1. Then interval, that is the interval between the cuts. 313 is what I typically use. That means my cut happens every 3/4 of a second, 720 milliseconds, about 3/4 of the second. All right. And if you increase the interval to 6, it's 1.2 seconds. So something to keep in mind if you want to adjust this. But I don't adjust my settings. I just put 313 for most of the lesions, except when the lesions are very juicy and have a lot of vessels. In that case, I may increase the interval to a longer interval for a lot more coagulation in between those cuts. I prefer to use a stiff snare for all my endoscopic mucosal resections. I typically use in the cecum anywhere between 10 to 15 millimeter snare. For those of you who are starting, if you want to play safe, take a smaller snare, 10 millimeter snare, and you will come out good with less complications. It may take a little longer, but you could easily cut it. And keep the snare parallel to the wall. And that is very important, especially if a lesion is going over a fold. You want to cut the front half, the top half, and the other half in that order rather than trying to cut across, in which case you will end up with a perforation. After each cut, get into the habit of examining the base to make sure the base has not doesn't show a perforation. And you anchor underneath the prior cut and then keep cutting until you completely cut the polyp. And once you cut it, you want to check for any residual polyp. That is really critical. If you don't see any residual polyp, you can do a few things to prevent the recurrence further from that microscopic disease at the edge. You could either consider organ plasma coagulation of the edge. I typically want to get a Brown effect. I typically use 0.8 liters of flow, 30 to 35 watts. That's what I use, and a forced APC with a forward jet APC. With this, in my own practice, my delayed recurrence rate is pretty low, between 3 to 5% over the last 10 years. Of probably more than 400 to 500 large polyp resections. Recently, Michael Berg's group has shown that you could achieve a very good result without the need to spend extra money with APC by using a soft coagulation and with the snare tip coagulate the edge. So if you want to resect and then use a snare for soft coagulation, by having endocut Q on the left side and soft coagulation on the right side, you don't have to keep changing the parameters. And that's one of the advantages to consider how you set up your electrosurgery unit. And let us talk about how do you manage bleeding. So I've told you that it's a good idea to set up your electrosurgery unit on the left side with endocut, on the right side with soft coagulation, and that's going to come in handy if you see bleeding after your cut. So say, for example, you cut and there's a vessel that's bleeding, and your snare is still in the field. You don't have to change the settings. You already set it up. You have the soft coagulation ready, and you can apply that soft coagulation with the snare to the vessel, and you could coagulate small vessels very easily. For some reason, if it doesn't work and bleeding continues because it's a bigger vessel for that snare, and then in that case, you could use a hemostatic forceps that can use the same soft coagulation setup for your snare and be able to achieve hemostasis. When it comes to hemostatic forceps application, you apply you close the vessel and lift it a little bit, and then use the soft coagulation. That is pressing the blue pedal. Sometimes the vessel is underneath an edge because the vessel has retracted under the resection edge. If that's the case, you cannot keep on burrowing with your hemostatic cautery devices. In that case, you can use a clip. If for some reason you're not able to control the bleeding and you still have a lot of resection to do, one trick I would like to share with you is you apply a clip, sit there for 2 to 3 minutes, let the thrombus form, reopen the clip, continue your cut, remember where that vessel was, come back and apply the clip later on. So there are, in addition to this study from Heiko Pohl, who has shown that clip application cuts down the risk of delayed bleeding, and it's especially useful in proximal lesions. And now there are meta-analysis showing that all the studies do support the use of clip closure for large lesions in the right colon. Then comes how do you manage a perforation? So let us talk about the wall of the colon. And once you cut, I suggest that as a routine, if you use saline, you put either indigo carmine or methylene blue to have it like a sky blue when you do the injection. And that solution will be taken up by the submucosal collagen and it stains blue. And when you cut and you see blue like this lesion is unlikely to develop a perforation unless you've used a lot of duration of cut and the energy has gone deep. But if you're cut fast with a 313 and your snare is tight, you rarely will end up with delayed perforation. So this is submucosa. Again, submucosa is still intact. There's no muscle damage. There is some muscle damage. If you see muscle damage, that patient is likely to develop delayed post-polypectomy syndrome or even delayed perforation. And this defect should be closed at the end of your procedure to prevent perforation. If a perforation were to happen or if there is a transmural injury, you should immediately close the defect to prevent escape of colonic contents into the peritoneal cavity. How do we manage a perforation? If the perforation is small, related to thermal injury, the colon is clean and there's no spillage, that patient's perforation is ideal for endoscopic closure. On the other hand, if it is due to mechanical injury from scope trauma and in a dirty colon with spillage of contents into the peritoneal cavity, that is not something you can get away with the endoscopic closure, and that will require surgery. So when it comes to clip closure, I suggest that it is important to apply your clip so that you don't see any gap in between the two blades after a closure, as you can see in this picture. And how do you go about doing that? Every clip, as you close, it retracts. If you need to compensate for that retraction by either moving your scope or moving your clip down so that you can achieve as it retracts by moving forwards, you get a deep approximation. So let us look at it. So as the clip closes, it comes back, but you have to compensate by moving it forwards so that you can apply a deep clip closure. So this is a very important principle to keep in mind. And once you close, it is important to take pictures on both sides to make sure that your clip is not hanging to one edge, but actually bringing the edges together. So how to manage a polyp that is tethered? So if somebody has done a partial resection and it comes back to you, there is a simple way to do, and I've been using this technique quite often. So what I do is I try to inject away from the scar and resect as much of the non-tethered area first, leaving the tethered area till the end. And when it comes to tethered polyp resection, I use a hot biopsy avulsion technique that will require changing of your electrosurgery parameter from endocut Q to endocut I. And I typically use effect 1. There is no coagulation. As you know, effect 1 has no coagulation in between the cuts. And I increase the duration to either 2 or 3. There's no magic to this. And keep the interval around 1 or 2. And I want to make sure that change has been read to me by my assistant. So make sure that change you're absolutely sure that you've changed that parameter. And then what you do is you hold the tethered area, put a little bit of tension, and then tap, tap on the yellow pedal of the electrosurgery unit, and that will avulse it nicely. And I've used this technique quite routinely. I have to say that I'm able to manage even a centimeter large tethered area without much recurrence. I'm surprised with that outcome. In some tethered polyps, you could also consider full thickness resection. That's a very good option. But you have to make sure that you're able to, you have the skill set, your team has the skill sets to do that. But I feel that if you practice how to do hot biopsy avulsion, you can manage a lot of polyps with $15 hot biopsy forceps or $20 hot biopsy forceps. So once you remove a large polyp, you need to come back for surveillance examination. And in order to find that, you have to place a tattoo. And how do you place a tattoo? I want to show you a technique that is well known. And I've asked my Angela Deal, my illustrator, to draw it for you. So you have, if you have a needle that's not been used, the first is you flush it with saline, and then use the spot or whatever tattoo that you use. And then as you flush the tattoo, you let the tattoo come all the way to your biopsy port. And that's where you ask the assistant to stop. And that means you have at least 1 more cc of saline in the injection catheter. And then you puncture about 3 centimeters distal to the lesion in the same plane as the lesion. And then once you create a saline bleb, you inject and fill that saline bleb with tattoo. And that way you have the tattoo going into the submucosal plane without going into the peritoneal cavity. If you know that your patient has cancer and you want to mark it, then you have to do either 3 or 4 quadrants distal to the lesion and take a photograph of the tattoo with the lesion. So I would like to share with you what are these resources that are available to the trainees from Mexico. I want to share with you that every week I post videos of endoscopic mucosal resection because majority of the lesions that you see in your practice, or at least in my practice in Houston, 90+% of cases that I see, I can manage with endoscopic mucosal resection. There may be 5 to 10% of cases that will benefit having a colleague who can do ESD. I don't do ESD. I ask my colleague, Dr. Philip G., who's in my practice, who does ESD, and he does beautiful work for those patients. So for those of you who want to learn EMR of different types of polyps, different locations, different configurations, you see almost there are over 300 videos of EMRs posted on my YouTube, and you can access them easily. The other thing is for the last 1 year, we started doing a Zoom session every Sunday. You're welcome to join. My colleagues, Roy Satikno from San Francisco, my colleague, Dr. Selvi Tirumurthy at MD Anderson, Sriram Parupudi from UTMB, and Dr. Sylvia Sandlunu, she's from Maastricht, Netherlands, and Ravi Shankar from Singapore serve as panelists along with my colleague Joseph Zhang. We present a case and we let the panelists discuss. Sometimes trainees join. We want the trainees to take a crack at it so that they learn from different minds about how to manage polyps. And I want to thank you again, and I hope you all stay safe. We've gone through a very tough time last year and this year. Just be safe, and just want to thank you again.